Thank you very much. I think another way to frame this topic is to ask the question, when do you really need to do more to correct the overall sagittal alignment versus when can you just treat the neurologic problem at hand? In other words, the myelopathy or the radiculopathy. And this is a really important question because the potential benefits of doing the deformity correction is that you treat all potential pain generators, you get better overall alignment, and you might also get better outcomes. But on the other side, we know that it's going to involve more fusion levels, there's greater morbidity, and there's the chance for not only more, but also bigger complications like junctional failures that can then beget even more fusion operations. So this is a difficult question to answer. And in order to do it, let me start by saying why I think the cervical spine shouldn't necessarily be treated like the lumbar. We all know that lumbar kyphosis and sagittal imbalance are very poorly tolerated overall. And patients like this are almost always going to be symptomatic. But in the cervical spine, kyphosis and sagittal imbalance are not necessarily pathologic and symptomatic entities. So in this meta-analysis recently of 21 studies and over 15,000 asymptomatic adults, they found that only 68% of normal people were lordotic, and the average was about 13 degrees from C2 to C7. So clearly, if 1/3 of normal people are kyphotic, then our job as surgeons is not necessarily to make every patient lordotic. Well, what about cervical sagittal balance, or CSVA? If you look at studies on CSVA on asymptomatic people, you'll find that normal values range anywhere from about 0.5 to 2.8 centimeters. So on the basis of that, should there be a target or goal CSVA also for all patients? What about 4 centimeters? That number often comes up in the context of this discussion. And the reason why it comes up is largely due to this study by Tong and the ISSG. And they should be congratulated for the tremendous amount of work that they have done on this topic. And what they looked at was 113 post-op patients who underwent a posterior cervical fusion, and they found that the CSVA correlated positively with NDI and negatively with SF-36 physical component scores. And in their regression analysis, a CSVA of more than 4 centimeters had the most significant correlation with NDI. And that's where that 4 centimeter number comes from. Now, again, this is a very important, impactful study, but I think we need to be careful about misapplying this information because the patient population here was not an asymptomatic normal population. These were post-op posterior cervical fusion patients with an average of 5.6 levels fused. So I think it's entirely appropriate to say that a CSVA of less than 4 centimeters is associated with better outcomes in posterior cervical fusion and deformity correction patients, but that does not necessarily mean that all cervical myelopathy and radiculopathy patients need to have a CSVA of less than 4 centimeters. And in fact, in this study by the Jefferson group, it was presented last year at CSRS, but I don't think it's in print yet, so keep that in mind. They looked at 1 to 3 level ACDFs, so these are not big deformity correction procedures, and they stratified according to their preoperative CSVA. So in the group greater than 4 centimeters, the CSVA went from 4.9 pre-op to 4.4 post-op. So these are not big corrections at all, but despite that, the NDI scores improved dramatically by 19 points. On the other hand, in the CSVA less than 4 centimeter group, it went from 2.4 pre-op to 2.5 centimeters post-op. Their NDI scores improved as well, but only by 11 points, not as much as in the other group. So paradoxically, in this study, the patients with the higher CSVA actually improved more, even though the CSVA was not actively corrected and remained greater than 4 centimeters post-op. So given all that, what are some general principles to consider when treating patients with this sort of imperfect alignment? Well, first of all, I think you have to determine if there is a true symptomatic deformity requiring correction, or if we're just dealing with what I call a radiographic imperfection. So how do you define a deformity that requires correction? Well, I'm going to quote Supreme Court Justice Potter Stewart, and he was asked to define pornography. And basically he said that he couldn't do it with verbal criteria, but I know it when I see it. And in the same way, I think establishing absolute measurement criteria for deformity correction is hard to do because X-rays alone don't tell the whole story. I think in order to require deformity correction, patients should have symptoms of cervical deformity. There should be pain, muscular fatigue from difficulty holding your head up, trouble with horizontal gaze. End-stage cases will have swallowing issues. And there should be some sort of externally visible deformity. In other words, if the radiographic malalignment is so subtle that you can't even see it on the patient externally, it may not be worth correcting. So here's an example like that. Isolated radiculopathy, no neck pain, no visible deformity, but a fairly substantial kyphosis, 27 degrees. We treated that with a single level ACDF and all the symptoms completely went away. I just can't justify doing a multi-level fusion on someone like this just to make the X-ray straighter. So in my opinion, the X-ray criteria, the measurements, can tip the scales in favor of doing a deformity correction, but the X-rays alone shouldn't really be the sole factor in decision making. We should be treating symptomatic deformities like this: chin on chest, multiple surgeries, solid fusion and kyphosis, needs a back-front-back operation with multiple osteotomies, again to correct the symptomatic deformity. Second general principle is to always do an operation that will, at a minimum, maintain and not worsen the alignment. So, for example, although laminoplasty was conceived to avoid this type of catastrophic kyphosis that you can see after multi-level laminectomy, it is true that some loss of lordosis and sagittal plane worsening can occur even after laminoplasty. So in my opinion, a patient like this isn't a great candidate for laminoplasty. Admittedly, there's only 5 degrees of kyphosis, which is certainly within the means of what the literature says is acceptable, but the CSVA is moderately positive, and this, in my opinion, is a setup for losing more lordosis post-op. Paradoxically, somebody like this is actually a good candidate for laminoplasty. They have an upper cervical kyphosis, but they have lordosis where it counts, where the spinal cord compression is. So we can do a laminoplasty on somebody like this, resolve the myelopathy, and maintain the alignment. Third principle is, whenever possible, improve the alignment at the operative level, as long as doing so doesn't unduly increase the risk or magnitude of surgery. So in other words, grab all the low-hanging fruit that you can. If you're doing an ACDF in a kyphotic segment, place the pins divergently such that when you distract, you generate some lordosis. If you are trying to improve alignment with ACDF, fill the disc space with as large a graft as possible for better maintenance of correction. So in that regard, my current graft preference is to use large footprint lordotic cages. And here's an example of a modest kyphosis that was treated with this approach. And last year at the CSRS, we presented a paper showing that the improvement in segmental lordosis with these cages is maintained at 1 year. However, if you use allograft, you lose almost 50% of the initial correction that you got by 1 year. Finally, correct any deformity that's causing cord compression. So here's a chin-on-chest patient, prior front-back surgery. There's leftover OPLL, with the cord being draped over the OPLL. In that case, the deformity is causing the cord compression. So we did an osteotomy to correct the chin-on-chest deformity and indirectly relieve the compression away from that OPLL at C3-4. So in conclusion, sagittal alignment's extremely important. But just like we don't operate on every single asymptomatic cord compression on MRI, I don't think we should make decisions about the need for deformity correction purely based on radiographic measurements. I think it's important to always think about alignment, but in doing so, we shouldn't turn every degenerative case into a deformity case. Thanks so much.